Technical team.
Sir, in next 1 minute, sir. Give me a minute.
Sir, I am receiving one pop-up live stream.
Yeah. Just a second. Just a second. Yes, sir. We are live. We can start.
Sir, please, we can start.
Okay. Good evening, everyone. Today's topic we discuss about the diabetes management. The topic is that tellers diabetic management, the patient-centric use of DPP-4 inhibitors. According to the incidence of and prevalence in the world, the South Asia, 90 million people uh, are diabetic. We have predicted that increase the number of these diabetic patients from 96% and reached up to the 152 million by 2045. The scenario of diabetic in India, according to the WHO, the 1 in 7 of the all adults with diabetic in the world are present in India. The diabetic patients, according to 2022, the 77 million people are diabetic in India. The overall prevalence in India diabetic is 11.4%, and proportional of undiagnosed diabetes are around 57%, which I have undiagnosed in India, and around 7% of patients have the more 70% patients have more than 7% of HbA1c. It means they are under treatment and they require more aggressive treatment strategy. Pathophysiology of diabetes, this is omnis octet. We know that the islet cells are important, that they increase glucagon secretions and in the impair the insulin secretion in the pancreas, that are important of omnis octet, which is involved in the pathophysiology of the diabetes. In the intestine, the incretins are decreased in level and the increased lipolysis reduces the glucose uptake. And the renal involvement is increase the glucose reabsorption, which increase the blood glucose level, and muscles are also decrease the glucose uptake. It means the utilization of the blood glucose are also decreased. And the liver is also involved in the omnis octet, increase the hepatic glucose production. Now next, and the natural history and progressions of diabetes, that we know that at the pre-diabetic stage, the beta cell functions are normal, but the functions of beta cells are decreasing from pre-diabetic stage, and insulin secretions also increases and insulin resistance also increases. But when the type 2 diabetes is onset, and that time the insulin resistance is also decreased, but the secretions are also static. And the postprandial glucose level and fasting glucose level are the constantly increase in all parts of the diabetes. Microvascular and macrovascular complications are occurs in the macrovascular complications are occurs early, and microvascular complications are started at the late stage. Next, the associated conditions in diabetes mellitus, the prevalence states that the hypoglycemic states are which associated with the diabetes in the 45% patient, and the cardiovascular disease associated with diabetes is equal to 45%, and abdominal obesity with diabetes is associated with 59.5%. So that patient that requires a drug therapy that reduces the hypoglycemia, CV, and weight beneficial natural effects that improve the complications of the diabetes that occurs in the diabetic patients. Next. The case study first, the metformin failure in diabetes, when the patients are using metformin, but as time occurs, the metformin effects are reduces, and these metformin drugs are not fulfill the criteria of the required to the control of sugar. A 61-year-old man with diabetes received the optimal metformin monotherapy for last 1 year. Front dose are 2000 milligram per day and has tolerated the treatment well. Patients reported that the 3 episodes of hypoglycemia occurred in last 6 months, and his body mass index are 28 kg per meter square, has worked hard, reduces from 32 kg per meter square. Last 3 years, patient recently suffering from food poisoning and resulting in vomiting for 3 days. Patient having the normal blood pressure, lipid are well controlled. He now present at the clinic with HbA1c is 7.8. It means the more than the required HbA1c level less than 7. What is the ideal management for this patient? So we should require that the metformin is not sufficient for this patient for to control the diabetes. For what to do next? So we can be use the other drugs which the improve the glycemic control. For this, we have the two options: the DB4 inhibitors and SGLT inhibitors. And DB4 inhibitors are patients with regular lifestyle changes. We prefer the DB4 inhibitors, and patients with irregular lifestyle changes, SGLT inhibitors are important in this management. Next, DB4 inhibitors efficacy and safety in the diabetes mellitus. Now we will discuss the importance of the sitagliptin in renal and hepatic dysfunctions. This dose modifications are required. In the kidney patients, when the mild reduction in the kidney dysfunction, we require the sitagliptin dose is 100 milligram OD. And when the kidney dysfunction is moderate, then we reduces the dose 50 milligram OD, and when it is severe, we can reduce it from the 25 milligram OD. But the linagliptin and the teneligliptin are not required to dose adjustment, and they may be used constant dose like linagliptin 5 milligram OD and linagliptin are 20 milligram OD. Another, the saxagliptin are also required to dose reduction in moderate to severe renal dysfunction. And in the hepatic dysfunction, we can require the sitagliptin. Up mild to moderate, we can give up to the 100 milligram OD, but in severe cases, we are not recommended sitagliptin. And the other linagliptins are also, we can use up to the moderate dysfunction, but we don't recommend in the severe liver dysfunctions. Next, pharmacotherapy of diabetes, 88 to 76. This is the flow chart. We indicate the how to manage the diabetic the patients when associated with the arteriosclerotic cardiovascular disease and the CVD instances. We can use the GLP-1 receptor antagonist and prove the CVD benefit. And SGLT inhibitors with proven CVD benefits, we can be used SGLT inhibitors. And patients associated with heart failure, SGLT inhibitors are more beneficial. And patients with CKD, there are SYNMX8537537L and ARB, we can use the SGLT inhibitors like empagliflozin and dapagliflozin. Next, the effect of sitagliptin on cardiovascular outcomes of type 2 diabetes. This is the TACOS random trial. Thus indicate that the patients are established CV disease, adding the sitagliptin in the usual care did not increase risk of the major adverse cardiovascular effect and hospitalization and heart failure. So we can safely use the sitagliptin in these patients to improve the cardiac complications and improve the glucose level control. Now the diversity of CVR studies, this is a study results show that the comprehensive study in the glycemic control using the CGM device. In this study, the results are show that now the stream study, this is the show the sitagliptin and serum lipid level, certificate of the sitagliptin on serum level in patients with type 2 diabetes, systemic review and meta-analysis. The results are show that the sitagliptin alone and in the combination with other anti-diabetes agents significantly reduce the serum triglyceride and LDL level in patients with diabetes. This means it decreases the cardiovascular complications which are related to the dyslipidemia. Next. Now the case study of second, that the managing of diabetes in obesity patients. A 47 years old man with BMI 27 kg per meter square, HbA1c 7.9, was on sitagliptin monotherapy of the 100 milligram per day for 5 years. His HbA1c after a year 7.2. However, this found that the difficulty in the lose weight. What is the ideal management strategy for this patient? So we can go for that. The sitagliptin monotherapy causes the suboptimal reduction in HbA1c. When the DP4 inhibitors are weight neutral and hence no effect on the weight is observed. So we can the SGLT inhibitors have to establish the well-controlled glycemic control and reduction in the weight reduction also. So we can use the sitagliptin with the SGLT inhibitors. Next, now the dapagliflozin and the cardiovascular outcome in type 2 diabetes. This is the declared TIMI 50 results. This saw the dapagliflozin in the patient with heart failure and result in ejection fraction. This is the phase second placebo controlled trial. This study show that the incidence of RRR decreases by 7% and 26% in the DEPA have failed studies. Now the next topic, sitagliptin with dapagliflozin. These two drugs combinations we can use the management of diabetes mellitus. That in significant reduction in the HbA1c, these two molecules 1 to 1.5%, and CV and renal risk factors also decreases by that, and CV renal complex also decreases by SGLT2 inhibitors. And the safety consideration of two drugs are that no overlapping toxicity. These drugs are not doing the overlapping toxicity, and also no increased risk of the CV and weight gain hypoglycemia. No drug interaction between the SGLT inhibitors and use of any other plasmid. These are the oral administration are the both are drugs, and in patient compliance are good. Now the comparison between the sitagliptin and dapagliflozin, the half-life for both are the same, and the contradictions are that the sitagliptin has in acute pancreatitis, diabetic acid, and type 1 diabetes and hypertension. And in dapagliflozin, the hypertension, diabetes, and type 1 diabetes are UTI in hypertension. For renal impairment, the sitagliptin requires the dose reduction according to the stage of the CKD, and dapagliflozin are not require so much dose reduction, but EGFR less than 15, that means this condition we could not prescribe the dapagliflozin. And hepatic impairment conditions, the sitagliptin also required in mild to moderate condition, 100 milligram body, but severe condition are contraindicated, and dapagliflozin is also not indicated in the severe hepatic impairment. And next, the real DEPSI real world study on assessing the efficacy of safety of the fixed dose combination dapagliflozin and sitagliptin in the Indian population. This study shows the results that after 12 weeks of treatment with the dapagliflozin and sitagliptin, there was a significant reduction in the HbA1c level from 8.9 to 7.2. There was also a significant reduction in the fasting blood glucose level from 178.8 to 124. That means that this combination also improve the HbA1c level and the fasting glucose level. And the next, patient with type 2 diabetes and heart failure. And SGLT inhibitors are the first line agent in the diabetic patient with heart failure patient that can improve the cardiac reduce the cardiac complications in the diabetic patients with heart failure. All experts agree that the ability of the dapagliflozin plus sitagliptin can be used in diabetic patients with heart failure without any compromising the another complications. Now the patient profile for the sitagliptin and the dapagliflozin, that the type 2 patient with the established cardiorenal risk, they will use this combination as an add-on therapy. The patient with type 2 diabetes with established cardiovascular risk and control on monotherapy, either metformin or another diabetic agents. Now the case study third, the identifying the patient dual in therapy in the type 2 diabetes. This patient, 53-year-old male, was diagnosed with type 2 diabetes on the treatment with metformin 1 gram per day for the 3 months. At this point, the HbA1c was the 7.9, and the dose was increased to 2 gram per day. 3 months after later, there was no improvement in the blood glucose level, And parameters hence is what from the combination with the sitagliptin 100 milligram with metformin 2 gram. A few months later, they should show that the application with the complication of breathlessness and dizziness, the cardiovascular was the found dead. He had abnormal sinus rhythm, indicating the tachycardia and had left ventricular infection was just about 50%. The ML was the 7.2 and borderline control of the fasting and hospital level. What is the ideal management for these cases? So now with the since the metformin monotherapy did not show the expected result in the patients to control the glucose level, then we use the sitagliptin metformin reducing the efficiency was only up to the 0.9%. So the cardiac complex regression reflects the significant acute failure with persistent infection and is the less than 16%. For that percent, we can add the SGLT inhibitors and to improve the cardiac complications with metformin and sitagliptin. Next, now the triple drug FDC approved the DP inhibitors and SGLT inhibitors in metformin FDC because these three combinations are improving the glycemic control, then blood tolerance, average hypoglycemia is low, and also associated with the decrease in body weight. The increased incidence of genital infections with the dapagliflozin, since with the dapagliflozin and immunotherapy, for which will be required to the patients which have the UTI, different UTI, we should not give the dapagliflozin. Reduces the pill burden to improve the patient adherence. The rationality in the sitagliptin, dapagliflozin, and metformin combinations, the different mechanisms, there are DP inhibitors, SGLT inhibitors, and the decrease available by the metformin and increase intestinal occlusion. So that the three combinations also have the octet mechanisms which reduces the glucose level in the body. And the half-life of the three food are same, 12.429 and metformin 7.62. Now this is efficacy, the effect of dapagliflozin, sitagliptin, metformin versus metformin, control and trial. Okay. Patient profiles, Sitajit at the end in terms of patient with the cardiovascular risk and acidic, uncontrolled mono and dual therapy. You will diagnose with 8.5 with the reduced cardiovascular risk factor. A key takeover for that is the sitagliptin, dapagliflozin, and metformin combinations as early initial complication will diagnose we can use these three combinations to reduce the renal and cardiovascular complication. But these are the three combinations are maybe initiated with the initial treatment. Thanks. Hello. Thank you.
Thank you so much, sir. Very beautiful session.
Okay, okay. Okay.
Sir, just a 2 minute. Any queries?
Yes.
Dear delegates, any queries, please chat box.
Any query, Rupinder?
Yes, sir. Just a 2 minutes, sir.
Okay.
Sir, I think no queries. Thank you so much, sir.
Okay, okay. Thank you.
Thank you so much. Technical team.
Yeah, we can.